Good afternoon and welcome to our newborn screening webinar. Today's session will focus on amino acid disorders, an important group of conditions that can be detected early through newborn screening. So before we get started, just have a few housekeeping items. This session is being recorded and will be available for viewing at a later time. We kindly ask that you hold all questions until the end of the presentation, as we will have a dedicated Q&A session following the presentation. If it does run into that we can't do a Q&A, we will take questions in the chat and make sure that when we send out the recording, we'll have the answers to your questions. And you can find an archive of our newsletters and webinars on our website, and the link will be provided in the chat. So now it is my pleasure to introduce our speakers, Callie Ferguson, and Ms. Ferguson is a metabolic dietitian at Johns Hopkins. Nadiv Weinstock, I hope I pronounced that right. Dr. Weinstock is a board-certified pediatrician and a clinical geneticist and currently a medical biochemical genetics fellow at Johns Hopkins. And then we have Shira Ziegler, and Dr. Ziegler is a board-certified pediatrician and a clinical and biochemical geneticist. So please join me in welcoming the Johns Hopkins genetics team. You guys take it away.
Great, thank you so much. We're really happy to be able to present to you today. You can see the slides. So we'll start. We have no disclosures, and we'll discuss a number of the newborn screening disorders that are involved with amino acid metabolism and the urea cycle defect disorders. We'll discuss both the diagnosis and also the clinical manifestations and the medical and dietary treatments. So just to get us started, I think when people think about inborn errors of metabolism, it can get a little bit overwhelming. You think back to your biochemistry days when you were either a medical student or an undergrad, but I do find it helpful to think about the underlying metabolism and the biochemistry because it helps you really compartmentalize these inborn errors of metabolism. So again, here are some pathways that you might never thought you would have to see again. But again, I think it's easiest to kind of help put these different conditions into buckets. So again,
Dr. Ziegler, sorry,
yes.
I don't think the slides aren't advancing.
Oh, thank you.
Sure. There we
now
go.
We are?
Yeah, there you go.
Okay, thanks. Oh, it'll be a lot easier if you can actually see the the pathways. Okay, great. So again, these are the pathways that you probably thought you would never want to see again. But it really helps us compartmentalize these different inborn areas of metabolism and helps us figure out how to both do the diagnosis, then also the management. So the basic premise here is that there's defects in macromolecule metabolism, meaning that patients with inborn errors of metabolism can't break down proteins, carbohydrates, or lipids. And again, this is a very broad oversimplification. We're not talking about the lysosomal storage disorders, peroxisomal disorders, sterile synthesis disorders, but these main buckets of either not being able to break down proteins, let's see, I think you can see this, proteins, carbohydrates, or lipids are the main pathways that we screen for on newborn screening. And so over here you can see, for example, these are the defects in carbohydrate metabolism, either our glycogen storage disorders or disorders of carbohydrate metabolism. Over here are the lipid disorders where we can't break down fats. Those are the fatty acid oxidation disorders. We also have the mitochondrial disorders where we can't generate enough ATP. The focus of today will be on these conditions where we can't break down protein, and we divide this into urea cycle defects and then the amino acid disorders. And in general, when we see defects in protein metabolism is when we get the most concern. These inborn errors of metabolism usually present most acutely, and we have to take most emergent action for these little babies, and that's why newborn screening is so crucial for these set of conditions. And again, just to kind of think about this, we are in the state of Maryland, but as you might know, newborn screening is different from state to state, also, of course, different from country to country. But even just within the United States, how newborn screens get reported out can vary. In our state in Maryland, if there is an abnormal newborn screen, it goes to our follow-up program and then gets called out both to the metabolic geneticist and the primary care provider concurrently. And then the metabolic geneticist usually takes the lead to get the confirmatory diagnostic testing. And you can see below in Virginia, it's a very different system. It only gets called out directly to a metabolic geneticist if it's a critical value. And if it's not critical, it goes to the PCP. So again, this is really why it's important as a primary care pediatrician, even if you're working in Maryland, to just understand the workflow and understand how we do the initial workup, because these different referral systems can change and vary state by state. So let's just look at an example of an abnormal newborn screen. You can see here, this is one that's flagged that's abnormal. It has an elevated phenylalanine and also an elevated Phe or phenylalanine to tyrosine ratio. You can see this here. This is what the newborn screens look like when they're integrated into Epic. It might be that in your practices it looks different, but you can again see the abnormal flag for this amino acid newborn screen, and then it specifically says which analyte is elevated. So in order to figure out the next immediate steps, the best resource is the ACMG ACT sheets and algorithms, which can be easily found online by just using a web browser and searching for ACMG ACT sheets. This is really our gold standard resource that we use to figure out the next steps with newborn screening. So you can see that these sheets here are divided based on metabolic defect. So again, getting back to the premise that knowing just what bucket your condition falls into and which analyte might be elevated will help you to figure out which group of conditions you should further investigate. So hopefully if you see this abnormal newborn screen for an elevated phenylalanine, you remember that phenylalanine is an amino acid. And so you can click this little drop down button here, and this will pull up all the amino acidemias and the abnormal analytes. Sometimes I'll tell the medical students, if you just want to click down on all these buttons, that also works if you don't remember which bucket your condition might be falling into. But what you can do again is you'll see that these are the analytes here in this column, and then you have both the ACT sheets and the algorithms in PDS format. So again, this one screened high for phenylalanine. So you can click into this row, and this is what you see, both the ACT sheets and the algorithms. And so PKU patients, these patients have a very common condition. They have a condition called phenylketonuria or phenylalanine hydroxylase deficiency. And these patients can't break down phenylalanine. That's why it's high. And these high phenylalanine or Phe levels can lead to intellectual disability from the neurotoxic effects of this increased Phe. And this condition is managed as an outpatient with low protein diet, specialty formula, and disease modifying medications such as sapropterin or the newly FDA approved drug sepiapterin. And so this is very important to identify early because it really changes the course of this disease presentation. On the right here, you can see this algorithm, and this is the workflow for the next steps in diagnostic testing. I won't belabor the fact that we all know that newborn screen is just a screen, and the next step is to send diagnostic testing. And you can see here the next step in diagnostic testing is plasma amino acids. In our practice here at Johns Hopkins, we are commonly sending both diagnostic biochemical testing and genetic testing concurrently, given the fact that genetic testing has gotten so much cheaper and a quick turnaround time. And this way we can really integrate the information both from the biochemical results and the genetic results to establish a diagnosis. And then here, depending on kind of what you're seeing with again, the biochemistry, will kind of lead you to different diagnoses. Again, the most common cause of elevated Phe is PKU, but there are other conditions that can lead to also this elevation in an abnormal analyte. And then over here, if you look at these following next steps, which is I'm sure is very busy pediatricians and pediatric providers, that's kind of what you're most interested in. This will tell you what steps to take. And you can see it seems pretty basic, just informing the family, ascertain the clinical status of the baby, consulting with a metabolic specialist, again, in the state of Maryland. You're getting notified concurrently, but these ACT sheets are written for the whole nation. So it doesn't necessarily presume that your metabolic geneticist has been already notified about this abnormal newborn screen. And then these last steps, evaluating the baby in clinic, and then initiating these confirmatory diagnostic testing. In the end, for most patients who end up actually having PKU, we can manage these patients as an outpatient by titrating both breast milk, sometimes given a specialty formula, sometimes not, depending on their phenylalanine levels and the severity of their disease. But again, I'll just kind of highlight that this red portion here are the next actions that you should take. And then again, just kind of thinking about PKU a little bit more and putting this into some historical context before we jump into the other amino acidopathies and urea cycle defects. Newborn screening was actually developed to identify PKU patients. I'm sure some people still call it in the nurseries and the NICUs the PKU as opposed to newborn screening, but as we all know, it screens for much more than just PKU, but that is why it was developed. And without treatment, patients with PKU were usually born typically, but then developed delays around 9 to 12 months of life. And then by 1 year, they had intellectual disability, microcephaly, eczema, an unfamiliar odor, and some had seizures as well. And many of these patients have required like specialty homes because they were not able to take care of themselves. And then in the 1960s, Robert Guthrie, who was actually a cancer investigator, who had a personal interest in PKU because he had a child with an intellectual disability, and I believe a nephew or a niece who was affected by PKU, became very interested in trying to screen for this condition. And he developed this bacterial inhibition assay, and the concept of using a dried blood spot as an inexpensive and effective way of preserving and shipping newborn blood to a central lab where testing could be performed. So really came up with this idea and universalized it to take these Guthrie cards that we call them, the filter paper, to be able to send that to a lab and then do the biochemistry that's needed to perform these screening tests. And he was a strong advocate for expansion of newborn screening, and also involved parents and advocates to expand this nationwide. And what was found is that if we could identify PKU early, we completely changed their clinical outcomes. So now with patients with PKU, if we can identify them early and change their diets, we have medical management as well, other treatments that have come online. These patients can have a completely normal development, normal intellect, and have a completely normal life. So again, thinking about the power of early identification, newborn screening, and then having that really change outcomes for patients. So I'm going to pass it over to Callie, who's going to talk a little just about general principles of how we treat these inborn errors in metabolism. And then we'll talk about some more examples of the specific amino acidopathies and urea cycle defects that are on the newborn screen.
Yeah, so our general treatment principles, of course, for these conditions is going to be diet-led because these are inborn errors in metabolism. So there are defects in enzymes that lead to substrate accumulation and the associated pathology with that condition. So looking at our simple schematic to the right, basically our goal is to limit what substrate A is going in so that we don't have that accumulation of product C and the associated pathology with that. And as Dr. Ziegler was saying, this is why newborn screening is so important, because this early detection allows for us to catch that sometimes even before we get that buildup of product C so that we can prevent any detriments before they occur. And so for our our mainstays of therapy, sorry, we can go back real quick, Dr. Ziegler. Our mainstays of therapy are two ways that we limit the amount of substrate A for these conditions. The first way is limiting the consumption of whatever the offending amino acid is for that condition. So the way we do this is a low protein diet, which I'm going to go over a little bit more in a second of how that looks for our patients. Metabolic formula may or may not be required, but often is. So this formula provides patients with everything they need in their diet besides whatever that offending amino acid is. So vitamins and minerals, since we're focusing on amino acid disorders, these would also contain carbs and fat that would make up the majority of their diet. They would just lack that. They would also contain all the other amino acids, just lacking the amino acid that's offending in this condition. A lot of our patients also need medical foods, which we also call low protein foods. So these are manufactured foods that provide little to next to no protein, usually like in the 0 to 0.5 gram range per serving. This is to provide them with basically extra calories that does not have any protein in them because the restrictions on their protein is so low. The problem with this is that there's only 2 companies that are available in the US. Cambrook and Promin are the 2 different companies. But because they are such small companies, you know, these products, there's a lot of outages. They're also very expensive. For an example, a loaf of bread is $21 right now, which if you think about anyone, but like, you know, a teenage boy, how quick they would go through a loaf of bread. It's a real problem. And we very seldom get insurance coverage for these foods. Luckily, there are some, you know, vegan and gluten-free products that people can utilize from grocery stores now, but they're often not going to be protein-free. They still are expensive, and there's, you know, it's not ranging all the foods that our patients may need or want. Their total protein requirements are going to be actually above the RDA because often the majority of their protein is coming from protein that's lacking, you know, those offending amino acids. They're not complete proteins, so we end up having to give them more to actually meet their protein requirements. And then the second way that we prevent this is by preventing catabolism, by not allowing prolonged fasting, taking careful consideration when patients are sick or have a fever, because when they're in catabolism, you know, they have to utilize their own protein, so we end up getting a release of full proteins that contain those offending amino acids that can put them into trouble. So this next slide, this is just kind of a snapshot of, this is actually an example of one of our patients about how his diet looks. I think it's a good way to really be able to understand and sympathize with how restrictive these low protein diets can be. So this is for a 35 kilo 8-year-old who has classical PKU. Energy needs would be the same as any general patient, so around 1950 to 2150. His phenylalanine needs are 360 to 400 milligrams per day, which equals about 7 to 8 grams of natural protein. And then we usually go to their total protein needs, 1.5 grams per kilo, and then that leaves us with 48 grams of synthetic protein that he would need for the day. So this patient is on a PKU formula that's made up to 40 ounces. It provides 48 grams of synthetic protein and around 655 calories per day. So that means that his meals would need to provide about 7 to 8 grams of natural protein and then around 1,300 calories, give or take. So this is how his intake looks. He takes some formula in the morning and a banana for breakfast, and then an AM snack of Rice Krispie treats and apple juice. Lunch is French fries and apple slices and Gatorade. In the afternoon, more formula and a bag of potato chips. And then dinner is formula, mashed potatoes with butter, iceberg lettuce and cucumbers and ranch, and then a dessert of a Jell-O cup or an ice pop. So obviously you notice with only 7 to 8 grams of natural protein per day, there's no animal protein here, there's no dairy. But what you might also notice is there's no grains, there's no rice, there's no bread, there's limited amounts of potatoes. French fries is actually like the #1 food for a lot of our amino acid patients. So it's not as simple as just a vegetarian or a vegan diet. These are very, very limited diets that take careful planning from our patients. And then this next, I should mention, so there's no low protein foods on this menu, but many patients do require that, especially to get to their caloric needs. This next slide, I just like to point out, so when you think of foods that contain protein, most people go to, meats, dairies, beans, stuff like that. But most things have some amount of protein in it. So it's always just good to see, if we're thinking about this kid who can have 7 to 8 grams of protein a day, a piece of bread has 2 to 3 grams. 1 cup of cooked pasta has 8 grams of protein, which is his entire protein allowance for the day. And most people do not eat only a cup of pasta. Most people eat much more than that. A cup of rice is 4 grams. Most fruit is around a gram, but that still counts when you only have 7 to 8 grams of protein to use in a day. Half a cup of broccoli is 2 grams. Broccoli is one of the vegetables on the higher end of protein needs, and of course, like one of the more accepted vegetables for kids. A medium bagel would be 8 grams, and then a medium French fry is 5 grams. So it's always just good to put in perspective what these kinds of foods, what the protein content is, and really to be able to grasp kind of what we're talking about when we talk about low protein diets. I'm going to pass it off to Dr. Weinstock to start talking about PKU.
Thank you. So I think just to do a big overview here, we're going to go through each of these conditions one by one. I think, again, from an overview perspective, they present so differently. We're not going to go through the biochemistry like with a fine comb here. We're not going to go over each of these presentations in like a very, very advanced way. I think each of them could have over an hour lecture. I mean, frankly, you just saw how useful it was from our team, how absolutely necessary it is for the dietitians and for Callie and for experts to help us as physicians as well, because there's just so much challenge with managing, just the reality of what does low protein or low amino acid mean for each of these conditions. But starting with PKU, Dr. Ziegler already went over this. Most of these conditions tend to be autosomal recessive, like this one. And that's because we're talking about loss of function. And in this case, when you don't have the PAH enzyme, phenylalanine accumulates, and that causes the symptoms that we described, which include some of the physical exam findings as well as the intellectual disabilities. And so the idea here is to protect our patients from getting sick by preventing long-term accumulation of phenylalanine in the blood, which causes detriments in the brain and also affects neurotransmitters as well. I think we could go to the next slide. It's also important, as I think most people are well aware, that maternal PKU is an entity. It was once thought that, incorrectly, that as long as you bypass the early developmental stages of an individual with PKU, that you could then unrestrict their diet and they could proceed with a normal life. And I think we know now, even for the individual, there's ongoing cognitive and psychiatric symptoms that may develop. But of course, there are teratogenic effects that can occur from a mother with PKU to a fetus that does not have PKU. They may be obligate carriers, but their symptoms at birth do not come from their deficiency of the enzyme, but rather the gestational effect of high doses of phenylalanine in the blood. And so that includes microcephaly, cognitive disability, heart defects, and these are present at birth. So whether or not that individual, they don't need a restricted phenylalanine diet, but they will have these teratogenic effects regardless. So that's why maternal PKU is so important. And in our practice, as a metabolic trainee here, I'm learning about the cases of the individuals over the years that have had that prolonged admissions. Hope we don't tend to do that as much anymore, but in some scenarios, to really optimize phenylalanine during pregnancy, we've had individuals with prolonged admissions to try to limit the effects on the fetus. And then Callie will talk about PKU management.
So our mainstay of therapy is limiting the dietary intake of phenylalanine. And this is the amount that patients can have is really dependent on their residual activity of PAH. Small amounts of phenylalanine are still needed for linear growth, for brain development. And that's really what we track to make sure that we have that balance. It's a very fine line of trying to keep Phe levels down, but giving them the most amount of protein we can so that they're growing appropriately, both brain-wise and body-wise. So we use those plasma amino acids in growth really to drive our management. Um, Formula, like I said, contains everything except the phenylalanine. It gives them the majority of their protein, and often a lot of their calories also come with formula. For PKU, their formula is also supplemented with tyrosine because phenylalanine breaks down into tyrosine, so they would end up being deficient in that if we weren't giving enough. Our goal Phe levels is 120 to 360. Based on studies that have shown that that's kind of that upper limit of where before we see any kind of detrimental effects. As Dr. Weinstock kind of touched on, it used back in the day when it used to be only really treating through those developmental years, at first only going to age 6, and then that number just kind of kept bumping up. And now really the mantra is diet for life because of those behavioral and skin and other kind of issues that we do see in high Phe, even in adults. Because of this low protein diet that they are on, they are susceptible to some different vitamin deficiencies, mainly vitamin D, calcium, and iron. Their formulas are formulated mostly with vitamin D and calcium for sure. Sometimes iron supplements are required, but those are kind of things that we always pay attention to and focus on to make sure that they are covered. In terms of drug therapy, there are a few drugs, and they really have improved the quality of life of a lot of our patients and allowed for liberalization of a diet. Tetrahydrobiopterin BH4 is a cofactor for PAH, and up to 50% of patients with PKU are responders, and we see decreased levels, which means we can increase their protein allowance. But it really depends on if they have some kind of residual activity, if this is going to be effective for them. And pegvaliase is a newer therapy on the market. It's an enzyme substitution that works despite residual enzyme activity. And for a lot of these patients, it leads to a completely liberalized, normal American diet, which sounds great, but there are daily injections. This medication also has a black box warning for possible anaphylaxis. And it also, we see sometimes up to 2-3 years before we see the effects of pegvaliase. So there are some drawbacks, but there are some really exciting drug therapies that have really impacted our PKU patients.
Okay, so moving on to the next categorical amino acid disease. This is maple syrup urine disease. And you'll see in the top left of the screen the time critical mark. So there are a number of, I mean, of course, any individual that's screened with newborn screening, especially if it's a true positive, will need follow-up. And we won't know that until we do the follow-up testing. There are some conditions that you cannot wait the weekend for. They might show up at day life 4 or 5 or 6. Well, those symptoms might already be developing. And so maple syrup urine disease is one of the medical emergencies. The classical untreated form of this condition presents with neonatal encephalopathy and leads to coma and death. So this one clearly is different than PKU, right? Where phenylalanine can lead to developmental delays down the road. Of course, that's time sensitive, but this is critical. And so the idea here is you have a defect in the metabolism of branched chain amino acids. And the amino acid that we care about in this scenario is actually leucine. So that is the amino acid that's screened for. And it's there's two sort of mechanisms here. One is the leucine accumulates, and the other is byproducts of the leucine, the keto acids, because the biology is complex, so accumulates. And the general picture is cerebral edema. And so what ends up happening is leucine and its byproducts accumulate within the brain, and the parenchyma of the brain swells, and that could lead to coma, herniation, death. And so this is rare, one in just under 200,000, also autosomal recessive. Again, presents with this neonatal encephalopathy picture and an undistinguished, like an undifferentiated case of a 4-day-old that presents with aggressive coma. This is on your radar. The other ones that are on your radar is just sort of a segue into the end of the talk are the hyperammonemic conditions, so the urea cycles and some other organic acidureas. So, when we see these children in the ED, if the newborn screen's not back, we get pneumonia, we get the blood gas, and then, of course, the amino acids, which do take time to get back. Okay, next slide. And so here's just, an example of MSUD. The brain swells and leads to very serious critical illness. Okay, so we have, especially in these acute scenarios, we have acute management and chronic management. And this does not just mean on the presentation of the case of an undiagnosed or early differentiated patient. Even on our patients with known diagnoses, we are very aggressive on both the acute and long-term management. So the acute management is probably the stuff that you guys are familiar with from, consult genetics back in residency or in training. This is often when we'll apply high-dose dextrose fluids. As a point to that, the reason we're giving high dose dextrose, yes, we want to prevent hypoglycemia, but really the treatment here is to stop catabolism or the breakdown of proteins. So actually, before giving dextrose, the first thing is eliminate dietary protein. That sounds obvious, but for a baby that's maintaining hydration with breast milk and formula, eliminating intake of protein via eliminating formula is not trivial, right? So obviously you need dextrose fluids in that scenario. So we want to eliminate the key offender of the protein where you have branched chain amino acids and specifically leucine. We also want to give high dose dextrose. Typically we do D10 in these scenarios at 1.5 to 2 times the maintenance rate, and that's to stop the body's need for energy and stop the body's means of breaking down protein to produce energy, because your body via catabolism can produce leucine. It's not just coming from the diet. And so that leucine will be as toxic. So we really just have to eliminate leucine either from the body's muscle stores or from diet. Sometimes we will also supplement other amino acids here, acutely or chronically. It's different at different institutions, in different scenarios. We avoid hypotonic fluids in this case. Often we're giving D10 half normal in this case, and others sometimes we give full normal with the dextrose because of the cerebral edema risk. And if the leucine's too high, you can treat them as though we would treat a hyperammonemic dialysis. So that is an option if the leucine gets to such high levels that we don't want to wait for the body to eliminate the leucine. We want to pull it right off. Chronic therapy, I'm going to segue into Callie's talk. I just wanted to mention here that in addition to diet and thiamine that we're going to talk about, liver transplants are emerging. And obviously, we're talking about treatment for severe individuals. So you have to weigh the pros cons of a transplant, but there are a number in our center's practice and others where these transplants have been really life-changing. And then you can have an unrestricted diet, and more importantly, can avoid the poor morbidity and mortality that comes even with, attempting to manage a strong diet.
So for the dietary treatment for MSUD for more chronically, so we are limiting the intake of their branched chain amino acids, leucine, valine, and isoleucine. But as Dr. Weinstock said, leucine is really our focus because that is what is neurotoxic. So these patients are also on formula and a low protein diet that is similar to PKU, except obviously they're different offending amino acids, but they contain everything besides those branched chains. And so since the formula has everything except the branched chains, we do often need some additional isoleucine and valine added to their formulas to get to our target levels. And they also compete with leucine across the blood-brain barrier. So we kind of want those, the valine and isoleucine a little bit higher so that it can outcompete our leucine. The goal for leucine and isoleucine are 100 to 300, and then valine is 200 to 400. We usually say like a 1:1:2 ratio for leucine to isoleucine to valine. But again, plasma amino acids and growth is really what drives our management, trying to make sure those levels are in our target range, but also making sure the patient's growing appropriately. The leucine is what is neurotoxic, but every instance of those high leucines really do impact the patient's IQ and their developmental outcomes. So we're very careful to try to manage that even before it gets to that acute cerebral edema level, even slightly high levels. We try to control outpatient to make sure that patients are developing as well as they can be. And thiamine is sometimes helpful to patients with residual enzyme activity, but for our classical MSUDs, there is no benefit that's seen. And then similarly, since it's a low protein diet, we have to be careful with vitamin D, calcium, and iron deficiencies. And something I didn't mention for all of these, we are doing early DEXA scans because of these, the possibility of deficiencies. So usually around age 5 and then yearly to make sure bone growth is on target.
Okay, so we have, I think, almost 4 conditions left with 15 minutes here. So I'm going to go a little bit quicker. The big picture for tyrosinemia, we're detecting tyrosine. This is a condition where, as you would see, tyrosine accumulates in the blood. And the main sequelae here are liver failure. So sort of a spontaneous infantile liver failure. You can notice the hepatomegaly, the ultrasound findings, the change in coag markers and LFTs. Predisposes one to hepatocellular carcinoma later in life. It can also cause other systemic issues independent of the liver disease, like a kidney failure, a renal Fanconi where you're losing electrolytes and the consequential growth failure rickets. There's also sort of interesting and parallel neurologic crises that sort of mirror hyperporphyria. So we'll talk about that in a second, but that next slide. So in this condition, byproducts of tyrosine, downstream of tyrosine accumulate, and those cause the liver toxicity and others. One of the byproducts, succinyl acetone, is what inhibits the heme synthesis pathway, and that leads to sort of actually a phenocopy of porphyria in terms of the pain crises. And I already mentioned the others, so we can go to the next slide. The treatment here is actually fascinating. So, someone found that nitisinone was a molecule used for a herbicide, actually, for plants. They have a similar biological pathway. And someone thought, hey, this enzyme, HPPD, is actually upstream of the defect in tyrosinemia. And some of those toxic byproducts I mentioned are downstream of this enzyme. So one asked if this toxic molecule that's an herbicide could actually be therapeutic, and in fact it is. So our mainstay of treatment in addition to diet is nitisinone, which has a brand name as well. And then of course liver transplant is also an option and may be necessary.
For tyrosinemia, our diet goal is to limit the intake of tyrosine, but we also have to limit the intake of phenylalanine since that is the byproduct of tyrosine. Very similar to other conditions, it's a formula and a low protein diet, but we do still need small amounts of tyrosine and phenylalanine for linear growth and development. But the majority of protein, and then often a lot of the calories also come from formula. As Dr. Weinstock was saying, for NTBC, that's our mainstay of medical therapy, because diet alone is not going to prevent us from having those high succinyl acetone levels. So NTBC is really an induced hypertyrosinemia. We have, if they're just taking NTBC but not following diet, we see very high levels of tyrosine, but that is much less dangerous and has more benign effects than the elevated succinyl acetone levels. We do interestingly see lower IQ in these tyrosinemia patients than general population, thought to be from these higher tyrosine levels. Our goal tyrosine is from 200 to 600, and then we want our branch chains and our phenylalanine to be within normal limits, meaning that they're getting that minimum kind of amount of protein that they're still growing appropriately. But as other conditions, plasma amino acids and growth is what drives our management. But it is kind of similar to PKU and MSUD, where we're around that 0.2 to 0.3 gram per kilo natural protein. So it's a very strict low protein diet.
Okay. The next is homocystinuria. So you may recall this condition extremely rare. I guess not extremely in the field of genetics, but rare compared to some of the ones we mentioned just by epidemiology. So it is a positive high methionine. And this is, in some ways, it phenocopies some of Marfan syndrome. It's got the Marfanoid habitus regarding the skeletal malformations. You may recall from your board exams the up versus down dislocated lens. That's not commonly used diagnostically from our end, but they certainly do have Marfanoid features and have eye abnormalities. The most clinically pertinent, in addition to the neurocognitive outcomes, are the thromboembolisms and the risk for clot and venous clot. So the big thing here is, like some of the conditions we've already seen, is that some of these residual enzymes will respond to the cofactor with pyridoxine B6. And so for an individual where a vitamin can help, change the outcome of a devastating disease, of course, we're going to try it. So that's typically what we do. And then we have the diet that we'll talk about as well. There are others in the pipeline. There's another molecule here called betaine, which you can see is on the pathway. I didn't mention the biochemistry here, but again, this is related to amino acid metabolism and leads to accumulation of and deficiency of a number of various molecules here that can cause symptoms. So there are things in the pipeline, but really we have B6, we have betaine, and we have diet.
For homocystinuria, we are limiting the diet intake of methionine. So again, with a formula and a low protein diet, but we still need those small amounts of methionine for growth and brain development. So they do get some amount of natural protein. Cysteine is conditionally essential for this condition, so it is in their formula. As Dr. Weinstock said, a B6 trial is done on all of our patients since there are some that are responsive. They get the higher dose. We do usually still leave even non-responsive patients on some amount of B6 since it is a cofactor. And they're also given folinic acid since B6 is dependent on it. B12 is given to assist in the remethylation of homocysteine to methionine. And then betaine is also given. It causes an increase in the methionine, but a decrease in homocysteine, which is what we're worried about for those thrombosis. So that's where that low methionine diet is important to give in conjunction with these different medications. Usually divided within 3 doses throughout the day. And our goal is for methionine less than 1,000 and homocysteine less than 100.
Okay, so frankly, that's probably the conclusion of the classic amino acids we're looking for. I do want to just talk about 2 categories, one more important than the other, the more important one being urea cycle disorders. So these are not quite official amino acids, but they're amino acid-like molecules that do show up on the amino acid profiles that we send and on some of the newborn screens. And so I do want to talk about urea cycle disorders because not all urea cycle disorders are found on the newborn screen. And so for that baby that I mentioned, the 4-day-old with encephalopathy that may or may not show up to, a practice or an ED, even with the normal newborn screen, we cannot rule out everything. So it's critical that we know what is on it and what is not on it and what we're looking for. So urea cycle disorders, really their symptoms are related to the management of high ammonia based on the urea cycle, which I'll show you on this next slide. You want to skip a slide. So that's a liver biochemical pathway for which we recycle ammonia into urea, which can be excreted by the kidneys. There are a number of enzymes involved. These enzymes hand off the substrate one after the other, forming a cycle. If you just advance one, I think you'll see, okay, so there are a number of ways that we can try to diagnose these biochemically, but it's not trivial because when you cause a defect in one of these cycle spots, the substrates will vary accordingly. So while they all may have high ammonia, ammonia itself is not a useful biomarker due to the difficulty of measuring that marker and the fact that it could accumulate artificially. So there are a number of different programs throughout the country and the world that measure various products here, citrulline, the high or low, or arginine being elevated. In Maryland, which we'll show on the next slide, we're really only evaluating for elevated citrulline. So really we can only distinguish arginosuccinic acid synthetase, which is citrullinemia, and arginosuccinic acid lyase, which is ASL deficiency, as well as a couple other mimickers. And we will not get the CPS1s or the OTC deficiencies or the arginase. Now, sometimes you can call it out if the citrulline looks 0 because we're not just getting a yes or no. We are getting a number. However, I think there are logistical difficulties with that. So what's actually being officially reported is just elevated citrulline. And of course, these are time sensitive. And Callie, you can go ahead with your recycle disorder management.
Yeah, so high ammonia is obviously an emergent situation. So kind of grouped into our acute management and long-term management. And as Dr. Weinstock said earlier, the acute management is not just on presentation. These patients often get acutely ill from stressors and illnesses. So our first priority is to clear that ammonia, use the different nitrogen scavengers and dialysis if needed. We reverse catabolism as quickly as we can, giving D10 at 1.5 to 2 times maintenance. Often, sometimes giving lipids or TPN as well to just support them metabolically while we have to hold protein. We hold that protein hopefully until ammonia clears, but we can't hold it too long or then the patient will become protein catabolic, which puts us into a vicious cycle. So really after 24 hours, we need to start kind of a stepwise of introducing a little bit more protein into their diet. For our long-term management, it is a protein restricted diet. The severity really is dependent on the extent of the deficiency and the specific urea cycle disorder they have. Into adulthood, it can be as low as 0.3 grams per kilo, but oftentimes it can be a little bit closer to 0.5 to 0.8, where we may be able to get away without formula. So we may or may not use formula. Arginine or citrulline supplementation is needed dependent on which urea cycle to kind of keep that cycle going. Essential amino acids are sometimes beneficial to help with growth, to give less of a nitrogen load, but still give them those essential amino acids so that we can see good growth, but hopefully control ammonia. And then nitrogen scavengers are used daily for these patients to also help clear that ammonia on more of a chronic schedule.
Okay, and lastly, a very rare condition that was recently added. This is GAMT deficiency or creatine usage pathway deficiency. So the amino acid-like molecule GAA accumulates. This leads to intellectual disability and epilepsy. We can supplement with creatine and ornithine. If you go to the next slide, you can just see that some of these pathways can be reversed. You can see on MRS a peak for creatine finally showing up in the brain, and so the brain needs creatine to be useful. So it's a good thing to diagnose if you can.
And just quickly, our management for this condition is giving creatine 400 to 800 milligrams per kilo per day and ornithine, and then it's an arginine restriction around 0.2 to 0.3 grams per kilo of natural protein intake. So a pretty strict low protein diet with the use of, again, formula that contains everything besides that arginine. Sodium benzoate is used to lower GAA by conjugating with glycine. And as Dr. Weinstock said, early initiation of treatment really improves outcomes, which makes it really important on newborn screening.
Great. Yes. So yes, that's basically our overview. And then just to reiterate, we did talk a lot about disorders that are covered on newborn screen, but of course there are conditions and inborn errors that are not covered on newborn screen. Dr. Weinstock mentioned a couple of them, and here's to list a couple others. There's mitochondrial disorders, non-ketotic hyperglycemia, and then the certain urea cycle defects that Dr. Weinstock already mentioned. And as we also mentioned at the beginning of the talk, as we discussed, newborn screens vary from state to state and vary from country to country. So even if you have a normal or a negative newborn screen, but there you still have a high suspicion for an inborn error of metabolism, remember that these are just screening tests, and you should move forward and either refer to metabolic genetics or send the diagnostic testing and move forward. But we certainly see some late cases of PKU or others from adopted patients from abroad. Things have changed and things continue to change. It's an evolving process.
I'm so sorry. I'm going to jump in here really quick. But we do actually screen for elevated citrulline. So we do have, Maryland, we do have that option. We do elevated citrulline.
Yes. Yes, thanks for clarifying.
You're welcome.
And then again, this is just the conditions that we discussed today, and what Callie really emphasized was our dietary and our medical management. And moving forward, we're really excited about thinking about how gene editing and therapy will also play a part in newborn screening. I'm sure some people have heard about the baby KJ story coming out of CHOP. This is a baby who was diagnosed with a urea cycle defect called CPS1. And they were able to use personalized CRISPR gene editing to correct one of these defective alleles in his liver. Again is a really exciting developments in genetics. So for conditions that we previously thought were essentially immutable, now we are able to mutate them back to normal. And as we kind of develop better CRISPR technology, both the gene editing and the delivery system, there's going to be a lot of new developments for these patients with inborn errors of metabolism, really at the forefront of personalized medicine. So eventually, hopefully, all of us will be out of jobs. That's our hope, but still lots to do to take care of these vulnerable patients. We'll just end there with our references and happy to take any questions.
I jumped in and said elevated citrulline, but
You meant
because I haven't, but we do screen for decreased citrulline, and we also report elevated arginine as well. So just to, and I know Dr. Dorley, our lab director, put that in the chat as well. So
yes. Sorry, I thought I saw a chat come up. Oh, here. The question is it worth asking, adding NKH to the newborn screens near fatal? I'm happy to take it. Dr. Wanstock, do you want to discuss?
Well, I mean, one point is that for the diagnosis of NKH, you often need the CSF glycine as well. So it's actually the diagnostic criteria, the elevated glycine in the CSF versus the plasma. Now, I don't know from a first screen if the blood glycine would help. I'm sure individuals have looked into that. I'm not familiar with where that is, but I'm sure that's one of the issues is the diagnosis. But there's strict criteria to get each of these conditions onto newborn screening, including both diagnosis, management, and intervention, a useful intervention.
Yeah, and as you know, I mean, NKH is there's always a spectrum for these conditions. You know, you've like the most severe and classical. These patients really, no matter what kind of intervention you provide, unfortunately have poor outcomes. Whereas the more attenuated forms, it's kind of unclear how much our management is making a difference. You know, unfortunately, a lot of these conditions are rare, so we don't have great natural history trials to see how much intervention has helped for NKH. I know for at least the patients that we take care of, we see variable responses. As opposed to at the MSUDs or PKUs, where we really see just drastic differences in outcomes.
okay. If there's no other questions, I will go ahead and close this out. So I think I just saw something. Oh.
Any improvements? We think you guys do a great job, and we know, I mean, we talk to Portia all the time. um, but I think our relationship between the lab and our institution, I think, has always been very positive. I think what's been helpful most recently is probably just getting the call outs via email as opposed to by fax. I think that's been an improvement. Just
Can you improve the humidity in Maryland for us so that
yeah.
those belts don't keep dropping?
I think that's something we can do. We can work on that.
Yeah. I mean, it's definitely, as you know, it really is just a team effort, between the patients and the lab and the insurance and our dietitians and scheduling. I mean, we really kind of move mountains for these patients when they have an abnormal newborn screen, to get them seen quickly and do the diagnostic testing. And so we certainly appreciate the lab's efforts to kind of report out quickly, even though that ends up being usually a Friday afternoon at 4 o'clock. And we really appreciate everyone's help and work trying to get these patients seen quickly. Great.
Right, great. So thank you so much. This was great. Thank you so much for tying it into, how critical it is for the overall care of the baby. So we definitely appreciate you. So for everyone else, we would also like to extend our gratitude to all of you for joining us today and for your continued commitment to advancing newborn screening and early detection initiatives. Your engagement and dedication is what make progress in this field possible. And as a reminder, today's session has been recorded and will be available for viewing at a later time on our website, in which I did provide the link in the chat. We encourage you to share it with your colleagues who may benefit from this valuable information. So on behalf of our entire team, thank you once again for your participation in today's webinar, and thank you to the Johns Hopkins team for taking time out. We know how busy you guys are, so we appreciate you taking your time out to do this for us. And we look forward to connecting with all of you all at future events as we continue to work together towards improving the health and outcomes of newborns and families everywhere. And have a good afternoon.